So I will be demonstrating the management of third stage of labour, as well as the estimation of blood loss and perineal assessment. So the woman I'm looking after today, her name is Sarah. She just gave birth vaginally to her first baby. She had discussions in the antenatal period regarding how she would like to manage her third stage of labour, and she decided she'd like to have her third stage of labour actively managed. When I entered the room towards the end of the second stage of labour, I would have brought with me what they call the baby bundle, which is all the equipment that I will need to manage the third stage of labour. I would have also drawn up into a 2 ml syringe the oxytocin, which I would have checked the contents and the label with the accoucheur. Usually oxytocin is used as the uterotonic agent of choice, as it is usually active within 2 to 3 minutes of it being injected. It has minimal side effects and it can be used by all women. So Sarah's baby was born 1 minute ago, and as I am the assisting midwife, I've helped her establish skin to skin with her newborn baby. I'm now going to administer the oxytocin. So I'm administering it intramuscularly. So I'm just going to pinch the skin and inject 10 international units of oxytocin. And I'm just letting the accoucheur know that I've done so. So while I'm waiting for the oxytocin to show its effects, I'm just going to change any dirty sheets that might be under Sarah and make sure that they're clean, just to make sure that she's not super cold. I'm also going to collect these sheets because I will be estimating blood loss later, and if there's any blood on the sheets, I'll need that in order to estimate my blood loss. So I'm now just feeling the cord to see if it's still pulsating, and it's not anymore. So I can now begin with my controlled cord traction. Now I'm just placing one of my clamps onto the cord, and I'm just going to milk the cord towards the baby. So now the cord's turned white, I'm going to place the second cord on. Sarah's partner's told me that he'd like to cut the cord, so I'm just going to advise him to cut between the 2 clamps. So now that the cord has been cut and the oxytocin's been delivered, I'm now just going to place my hand on the fundus. Now what I'm looking for now is signs of placental separation before I begin controlled cord traction. So signs of placental separation include a uterine contraction, fresh blood loss, or lengthening of the cord. Now I'm feeling the contraction now and I can see the cord's lengthened. So I'm going to now begin my controlled cord traction. So I'm just going to move the clamp closer to the woman. Now what I'm doing is I'm placing my hand onto the level of the symphysis pubis and applying counter pressure. This is called guarding the uterus. With the onset of a contraction, I'm gently pulling down, following the passage of the birth canal until I can see the placenta. Once I can see the placenta, I'm going to use both hands to gently twist the placenta and ease it out of the vagina. This is going to collect all the membranes together. I'm going to place the placenta in the kidney dish that was in the birth bundle and then put it to the side. It's also important that once the placenta is birthed, I document the time that it was born. Doing the placental check is important to make sure that there are no fragments of the placenta that remain inside Sarah. If there are any fragments that remain inside her, she's at risk of having a PPH, as the uterus will not be able to contract down properly. So now I'm going to ask Sarah if it's okay if I complete the perineal assessment. So I'm just going to explain to Sarah that what I'm going to be doing is just checking her perineum to see if she has any tears that require stitching. Once Sarah has consented to me performing the perineal assessment, I'm going to ask her if she requires any pain relief and for her to let me know if the procedure gives her any pain, and if so, I can give her some kind of pain relief. So before I begin the procedure, I'm just again going to change the blueies and the Kylies underneath her and hold and make sure I keep them to the side. Before completing the perineal assessment, I've made sure that I put on some sterile gloves, which I prepared in a sterile field. I'm now going to wrap some gauze around my finger, place it in some sterile water or some saline water. This will just make it not so scratchy when I perform the assessment. I might ask one of my assistants or the accoucheur to shine some light onto the area. This will make it easier for me to see the assessment. I'm parting the labia with my fingers and I'm just assessing the area to see if there's any tears here. I'll then move inside the vagina, assess the top of the vaginal wall and down along the posterior vaginal wall. This will lead me out to examine the perineal skin and then down towards the anus. What I'm looking for is any excessive bleeding that doesn't resolve with pressure, as this might indicate that she will need some stitches. Once I have done the examination, I'm going to report my findings back to Sarah, let her know if she needs any stitches, and then also document this down. So the final part of my demonstration is estimating blood loss. As mentioned, I collect all of the linen that may have any blood on it. What I would now do is collect all of that linen, blueies and kylies, take them to the pan room and weigh them. Once I've weighed them, I would then calculate, based on how many things I have, the dry weight of what I have, and then minus this from the total weight. This will give me the estimated blood loss, which I can then document down.